Bisphosphonates are the first group of medications we're going to go over. It is first line. We have a lot of data on them and we know that they work. The way that they work is that they bind to hydroxyapatite in the bone, so they're kind of hidden in the bone there. And when osteoclasts come in and try to break down the bone, they come in contact with the bisphosphonates, and then it basically prevents the osteoclast from going. The bone effects between each of the bisphosphonates is different. The most potent is zoledronic acid, and then I put it in order of potency. So the first one is it just has a better binding in the bone. It lasts longer there. And also take note of the different indications that these medications have. So ibendronate is really FDA indicated only for osteoporosis in women. And then eladronate and risedronate are pretty much the same, but it also includes glucocorticoid-induced osteoporosis. And then finally, zoledronic acid here, which is the most potent. We have this additional indication where we are preventing secondary fracture. So we want to make sure we're using the most potent bisphosphonate in a patient who already had a fracture because they are going to be at an increased risk to have another one. The dosing is going to be different for all these agents. First, we have eladronate, which is, it comes in a tablet solution and a effervescent tablet. This is given weekly. Now, note that the prevention dose is different than the treatment dose. Then we have risedronate, which comes in a tablet that can be given monthly, but there's also a delayed release tablet that could be given weekly. Ibandronate comes in both tablet and in IV. The tablet can also be given monthly, and then the IV is given every 3 months. Lastly, we have zoledronic acid, which is an IV infusion, and this is going to be the best option for those who might not have the greatest adherence because this is only going to be given yearly. And again, note the different in the different in how often you'll give it if this is being used for prevention. So that's going to be every 2 years. There are different additional products that are made to improve adherence. So for those patients that might be low in vitamin D or calcium, there is a product where they combine the two, and that's going to help with adherence. So the patient doesn't have to remember to take their bisphosphonate and their vitamin D or calcium. The dosing and renal sufficiency, we have cutoff points because they weren't studied as well in these populations, and that's because the indication for or the reason for osteoporosis or low bone density is going to be different in patients who have CKD versus the whole pathology that occurs in osteoporosis. So zoledronic acid is contraindicated if the creatinine clearance is less than 35. But also take note that there are other risk factors that can make it contraindicated as well. Then we have oral bisphosphonates where we want to be cautious if the creatinine clearance is less than 30 in risedronate and ibandronate or less than 35 in alendronate. And like I said, it's important to distinguish whether a person has osteoporosis because of age-related or medication-related versus someone who may have low bone density because of kidney disease, because the two processes are completely different. Now, let's say the patient does have osteoporosis because of, let's say, drug-related reasons. That doesn't mean we can't use bisphosphonates. That just means maybe we could reduce the dose of the oral bisphosphonates. And we don't have an exact dose, but just for the purposes of this presentation, just kind of know that you would have to reduce the dose. There are specific administration instructions that you have to tell the patient when they take these medications. First is with the oral bisphosphonates. We want to tell them to take it with plain water. We don't want mineral water. We don't want milk. Milk has calcium, and there could be some interaction with the bisphosphonate and the calcium. It should be taken on an empty stomach, at least 30 minutes before food and beverage, and this is just going to help with the highest absorption. The patient should remain upright for 30 minutes because it could cause some esophageal irritation or some GI discomfort. So make sure they're sitting or standing. And this should not be taken with other medications because there could be some interaction. So this is going to include calcium. So make sure that they are separating those medications. For the effervescent tablet, there's specific instructions on how to dissolve it, what to dissolve it with, and then this one is really made for patients who maybe that can't swallow pills. So now we have a liquid that the patient can take. The delayed release risedronate, this one can actually be taken 30 minutes after breakfast. So maybe this is a good option for the patient who keeps forgetting to take it before food. And then ibandronate, this one needs to be taken 60 minutes before food and beverage. And then also they have to be upright longer. So instead of 30 minutes, they should be upright for 60 minutes. And for this specific medication, we want to look for any drug interactions. So warfarin and acid suppressant medications are two of the main ones, but just make sure you run an interaction just to make sure that the patient knows the effects, or maybe you might just have to separate the two medications. Now, let's say that the patient misses a dose. If it's something that's taken weekly, you could just take it the next day, as long as there are 5 days in between the two doses. For the monthly dose, take it as soon as they remember, and then as long as there's just 7 days in between this dose and the next one that's due. For IV administration, it should be administered at a center by a healthcare provider, and it's important that the calcium is measured prior to administration because we want to make sure that the calcium isn't too high. So this has to be corrected prior to administration. So ibandronate comes in an injection, and it's really quick. You administer it over 15 to 30 seconds. And then we have Reclass that comes in a ready-to-use bottle, and it takes a little bit longer. It's going to be about 15 minutes to infuse it. It's important that hydration occurs before the infusion, and then also because there could be some reaction with the IV bisphosphonate, you could give them Tylenol to prevent this. It's important to note too, though, that Zometa is a different dose of zoledronic acid in the form of IV, but it's only used in cancer. So don't use those interchangeably because they are different doses. The adverse reactions that I mentioned is irritation in the GI, so it could cause some nausea, abdominal pain, heartburn. So that's why we tell the patients to sit upright either 30 minutes or the 60 minutes, depending on the drug. They might also notice some muscle, bone or joint pain, but this is usually reversible. It makes sense that this might happen because this bisphosphonate is essentially going into the bone. For IV administration, like I said, they might notice some of that acute phase reaction, fever, chills, but Tylenol should help with this. And so there is poor adherence with these medications. So this is kind of a target where pharmacists can intervene and make sure that we're giving the patient the best option. So let's say they're not taking their weekly medication, maybe we might want to switch them to a monthly regimen, or perhaps they're really not adherent at all and maybe they might benefit from something that's given yearly. So we as pharmacists, we can easily assess this and maybe bring it up to their PCP and have them change the drug. Denosumab is another anti-resorptive medication. It's a monoclonal antibody. So remember that diagram we talked about? What happens, it's going to bind to the RANK ligand. So then it's going to prevent osteoclasts from doing its job. So essentially we're preventing any more bone breakdown or bone resorption. It has a very long half-life of 32 days, but also note too that the concentration can really peak anywhere between 5 to 21 days. It lasts up to 9 months. There's no renal elimination, so this is a good product for any patients that might have some reduced renal function. Just note that the effect is lost after 6 months, so that's when we want to follow with bisphosphonate. This medication is indicated for women and men who are at high fracture risk. So that's going to be someone who already had a fracture related to osteoporosis, someone who has multiple risk factors, or cannot use other meds. It's also used for androgen deprivation therapy for non-metastatic prostate cancer, and it could be used in conjunction to aromatase inhibitors for breast cancer. You will understand a little bit more of why when you get to that section in your learning process. The bone effects are cumulative increases in bone mineral density for at least 8 years, and this is going to be helpful in the vertebral, hip, and non-vertebral fracture prevention. So this is it has long effects. That's good to know. We want a drug that lasts long rather than something that you take for a month and then immediately starts to lessen the effects in the next 4 weeks. That's not the best medication that we would want. This drug comes in an injection, and the duration of how long you would want to use it really depends. It could be anywhere up to 5 to 10 years, but you want to look at the patient history and see kind of what's going on, and then reevaluate how long the patient might actually need it. So like I said, it's a pre-filled syringe. Just make sure that they don't have a latex allergy, because the tip does include rubber. The patient should make sure it's refrigerated, but when it's ready to use, it should be brought into room temperature, and then it should be administered within 30 minutes. Good thing that this thing has a safety guard needle, prevents any accidental pokes, and just important to use a proper disposal of needles, and preventing any accidental needle pokes. So just alert the patient too, to make sure they look at it. Just make sure it's clear, colorless, kind of just a quick way to make sure it hasn't expired. And this could be injected in the upper arm, the upper thigh, or the abdomen. Some of the adverse reactions are hypocalcemia. There are no renal adjustments required, but this is something that you should keep in mind, because hypocalcemia is common in chronic kidney disease. So we should make sure that they're not already too low before we give this medication, because this would bring it down even lower. There are some warnings they should look out for. There could be some serious infections, osteonecrosis of the jaw, suppression of bone turnover. Although it doesn't happen very often, the patient should just be made aware. Some more common adverse reactions are back, shoulder, leg pain, increased cholesterol, and cystitis. There are specific prescribing processes that you have to think about when this is prescribed. Prescriber does need to do prior authorization and go through REMS. The patient needs a medication guide so that they have all that information with them. And the patient might need some assistance in covering this medication, and Prolia Plus is something that can help determine if the patient has the insurance coverage for this medication.